You're all welcome from all corners as you have come. My name is Rita Twahe. I'm going to be your host this morning. I'm the head of grants at Maristops and have been the RISE program manager over the past nearly 6 years. I would like us to start our day. We've already had a few videos and a few photos from the program, but would like, before we begin, we start with a prayer, and then after we'll do introductions. If you can please show the program. You have the program on each of your tables. If you have an iPhone, get your camera, point onto those very many dots, and you should have the program on your phone. If you have an Android phone, you need to have a code scanner. Please open it up, and you'll see those table talkers. They should be able to give you both the program for the day and the RISE program project brief. But for us to be all at the same time, we'll just have the program displayed now. And as you can see, we're a bit behind time, but we will be able to make up that time. We're supposed to have arrival and registration 8 to 8:30, and opening prayer and introductions thereafter, welcome remarks, then a presentation, a brief presentation on RISE, what is it we've been purposing to do and what have we achieved, and we'll have a bit of an interlude, and then go to a bit of learning. Where have we been in terms of equity or the inequity in SRH provision in the country? And we'll have some remarks from UNFPA, and we'll have tea, and then we'll have remarks from the outgoing chair of the Parliamentary Health Committee on some of the advocacy work we have supported as a program. And then we'll have remarks from the British High Commission, and then we'll have chief guest remarks, and we do have at the end some merit awards which will be given out. I would like to welcome each one of you once again, and we'll start with an opening prayer. To do our opening prayer, and I'm here looking for Jackie. Yes, thank you very much.
Thank you so much. Can we humble ourselves unto our word of prayer? Lord Father, we thank you so much for this great morning. We thank you for the great work that you've enabled us to do. We pray that you continue to grace us with the dedication, energy, and good health. We thank you for this great program that has been able to impact on people. We pray that it will be able to be sustained, and we continue to realize impact out of it. We pray for your blessings and favor throughout the day and the week. In Jesus' name we prayed.
Very much. That's powerful prayer. So we'll start with introductions, so that we can all know ourselves, and especially where we're coming from. And if you can also just take a few seconds to say something that has made you happy this morning. And I'm going to start on this end, and I'll ask Sandra to have a microphone on that side as well.
Yes, good morning. My name is Aida Mwanguzi. I am the Assistant District Health Officer, Kalungu District. And I'm happy to meet people that I've worked with in the consortium. And I know there's a lot that is going to be shared today. Thank you.
Morning, everyone. My name is Anna Tukahirwa. I work as ADHO, MCH Karoro District. I'm happy because God has brought us safely. Thank you.
Thank you very much.
Good morning, all. I'm called Ruth Akurut from Abim District, a midwife from Ramuge Health Center 3. I'm happy to be here.
Good morning, everyone. I'm called Willie Florence Ochin from Abim district. I'm a midwife working as a district trainer for Maristop, Abim district. Thank you.
Morning, everybody. I'm Teresa Kello, ADHO, MCH, Abim district. I'm happy to be invited for this particular meeting. Thank you.
I would like to propose as they introduce themselves, if someone has traveled a longer journey than you clap for them. Okay? I think it is important we do that. So let's proceed, please.
I'm Olive Sentumbo. I've just traveled from Kololo.
What should I say after that? Good morning, everybody. I'm Dr. Lidan Sekabembe. I work for PSI Uganda. I'm delighted to be here to share in the joys, the highs, and the lows of the RISE program as it contributes to Uganda's development. Thank you.
Good morning. My name is Batu Sajoy. I work with Clinton Health Access Initiative, also known as CHAI. I'm happy to be here, especially to learn about, the wonderful work that Maristop and partners have done in the space of reproductive health. Thank you.
Good morning, everyone. My name's Dr. Rachel Beajila from the Ministry of Health.
So this table are all from Kololo. So that's why we're not clapping for you. We'll take this table.
Good morning. I'm Dr. Gloria Kasozi from the United States Agency for International Development, USAID.
Teko Timothy from NAPAC, the District Health Officer.
Good morning, all protocol observed. My name is Natianga Sumta, ADHO NAPAC.
Good morning, ladies and gentlemen. Faith Nachiimba, DHO Masaka.
Good morning. My name is Mugabi Simon Peter. I've traveled the longest distance than any one of you here. What has interested me is meeting Malo from Karenga. So we've traveled together. Thank you.
Thank you very much. I'll pick this table.
Happy to be here. Good morning, everyone. I'm Chitimbo Patrick, DHO Iganga. Thank you.
Good morning, ladies and gentlemen. My name is Betty Chadondo, and I'm from Chadondo, so maybe I don't need to. But I work for the National Population Council, and I'm happy to have been associated with this program.
Good morning, ladies and gentlemen. My name is Nsibambi Douglas, working with FHI 360. We've been partners on RISE. Thank you so much.
Good morning, everyone. My name is Sanyu Kalibala. I'm the country manager of DMI. We were SBCC leads for the WISH program, but we worked very closely with RISE. Very happy to be here. Thank you.
Thank you very much, and good to see you, Sanyu, and colleagues on that table. I'll pick you.
Innocent Nkonwa, DH Allwell.
Rastomanji, DHMCH Rakai. I'm delighted to be here.
Morning, colleagues. Mlema Derek, EMMS Rakai.
Good morning, everybody. My name is Lydia Najemba Wasula, Minister of Gender, Labour and Social Development.
Good morning, everyone. My name is Jingo Ernest. I write for The Observer.
Over to you now.
Good morning. My name is Richard Obeti, DHO Bunyangabu.
Good morning, Lucy Kabasinguzi, ADHMCH Bunyangaba. You're welcome.
Good morning, everyone. I'm by the names of Harriet Kabasomi, registered midwife from Bunyangabu district in Western Uganda.
Morning, everybody. I'm Bira Joy Bibian, senior nursing officer from Kasese, district trainer.
Yes, good morning all. My name is Frederick Makumbi from Makerere University of Public Health. I'm glad to be here and for allowing me to rise with you.
Good morning. I'm Jackie Katana. I come from an organization called Faith for Family Health Initiative. But for accountability, I'm here to represent the reproductive, maternal, neonatal, adolescent health, nutrition, and health aging platform, RAMNAC plus N, where we all belong in reproductive health. I also represent CSOs at global level on Global Financing Facility Investors Group, and FCDO is one of the key investors. Investors mean the donors who put money in the reproductive health. Thank you.
Good morning, everyone. My name is Noor Nachibuka Musisi. I am coming in from the Center for Health, Human Rights and Development, SEHAD, and I'm representing Ms. Fatia Changi. Thank you.
Thank you very much. I'll pick this table.
Good morning. I'm James Magezi Akiki, DMMS from Kagadi District.
Good morning, ladies and gentlemen. My name is Theodora Kajumba. I'm ADHO MCH from Kagadi District. You are most welcome.
Good morning, everyone. My name is Patrick Mujigo. I work with the Partners in Population Development Africa Regional Office that we acronym PPDR. And we've been one of the implementing partners on the RISE initiative, implementing the advocacy component. I'm glad to be here.
Good morning to us all. David Walakida. I'm representing Options, a RISE partner.
Good morning, everyone. I'm Grace Namata, Senior Program Manager at the British High Commission, and I've been the RISE Program Manager. Thank you.
Good morning, everybody. I'm Dr. Rita Wadimba, the Country Director for Pathfinder in Uganda, and the Chief of Party for the USAID Uganda Family Planning Activity. It is humbling and a great privilege to be part of the RISE journey. Thank you for organizing this event.
Good morning, ladies and gentlemen. I'm Annette Kabarunji. I'm an Assistant Commissioner from Ministry of Gender, Labour and Social Development.
I'm here. Thank you very much. I'd like to pick this table.
Good morning, everyone. Tina Wamala, Communications Officer, British High Commission.
Good morning, ladies and gentlemen. My name is Maureen Katende, and I'm the Program Manager at the British High Commission, UK Aid, FCDO, call it what you want. And yeah, I'm happy to be here, and I've been the Program Manager on RISE.
Good morning, everyone. I'm Ian Ayebare. I work with the British High Commission as a monitoring and assurance officer.
Good morning, all. Happy to see you all. I'm Brenda Kabibi Tumsime. I'm a policy officer with the British High Commission.
Good morning, everybody. I'm Margaret Aricha,
program assistant for this program. I'm happy to meet the RISE team, to see the faces. I've been working with you in the background. Thank you so much.
Thank you. I'll pick this table.
Good morning, ladies and gentlemen. I'm called Sheikh Semwanje Nassa, and I'm the Secretary for Public Health, the Muslim community.
Good morning, ladies and gentlemen. My name is Eva Nachimuli. I work with PPDRO, Partners in Population and Development, the Africa Region Office, a RISE Consortium member, and I've been the coordinator at PPDRO as we're pursuing policy and funding advocacy.
Good morning, everyone. My name is Lilian Nabatanzi Subuga. I work with the Parliament of Uganda. I coordinate issues of reproductive health with the members of Parliament.
Good morning, ladies and gentlemen. My name is Mwima Rebecca, and I work with PATH.
I may pick your table. I'm good to see you.
My humble greetings to you all, ladies and gentlemen. I'm called Dr. James Lemcol, the District Health Officer, Moroto.
Good morning, everyone. Chobija Monica, District Trainer, Wakiso.
Yes, good morning, everyone. I'm Namtos Juliet. I'm a nurse. I work at Wakiso. I'm at Wakiso local government. I'm a family planning provider. Thank you.
Hi to everyone. I'm Drichiru Christine from Koboko District. I'm the proprietor of Koboko Hope of Glory and the service provider. Thank you.
We should also all be clapping because I think she's traveled the farthest, isn't it?
Good morning, ladies and gentlemen. I'm Lilian Sanyu Kebirungi Samantha Amoti. I'm here to represent the Kingdom of Toro. I'm the Youth Administrator of the Toro Kingdom Youth Ministry. Thank you.
I am also called Abwoli, so that if you don't know that, it is captured. But good to have you.
Good morning, ladies and gentlemen. I'm Nachitio Costancio, Assistant District Health Officer in charge of maternal and child health, Luengo.
Good morning. My name is Christine Mugerwa Kasule, and formerly a minister in the Buganda Kingdom, in charge of cabinet and Luchiko affairs. I'm happy to be here. I've seen some people that we have worked with in the past. Dr. Betty Chadondo, I heard her introducing herself. So I'm very happy to be here and see them once again. Thank you very much.
I also have a non-name, but we'll talk about it later.
Good morning, colleagues. Call me Adil Florence, ADHO Maternal Child Health from Koboko District. I don't know how many of you have ever reached that place. I'm happy to be here.
Good morning to you all. My name is Draru Jessica Andrea. I'm Assistant District Health Officer for Maternal Child Health and Nursing for Maracha District Local Government. I'm happy to be here.
Good morning, ladies and gentlemen. My name is Lameru Lois. I'm a midwife and district trainer from Koboko District. I'm happy for Rice and Mary Stop to make me feel at Serena for the first time.
Good morning to you all. My name is Sechanzi Adrian, proprietor Nyang Medical Services, that is in Chengera Town Council. I'm also delighted to be here. I myself am a testimony, and I've come here to testify for the good services Rise has brought to the communities we serve. Thank you.
Morning, ladies and gentlemen. My name is Betty Nabuganda. I am an Assistant District Health Officer in charge of maternal and child health in Wakiso. I think I've traveled the longest jam.
Yes, the longest traffic jam, I agree, and it's a Monday morning, so yes, you're most welcome.
Yes, good morning, ladies and gentlemen. I'm Dr. Kwairo Justin, DHO Nebi.
Good morning, everyone. I'm called Ovonji Patricia, enrolled midwife, service provider.
Good morning, everyone. I'm Irene Nandutu. I work with Population Meeting Center, Partner Rise.
Good morning, ladies and gentlemen. Becca Achid is my name, substantively as Assistant Inventory Management Officer for Health, Maracha District Local Government, and also given the assignment of District Medicine Management Supervisor. Thank you.
You're most welcome. I'll pick this table here.
Good morning, everyone. My name is Angela Ogera. I work with Mary Stops as the Director in charge of social business.
Thank you.
Yes, good morning, everyone. Martin Agawa, Head of Programs, Mary Stops. You're most welcome.
Good morning, I'm Benson Muhindo, and I work for Rich Hand Uganda as the Head of Programs, and we were part of the RISE program as the youth partner. Thank you.
Morning, everyone. I'm James Kasuja, the RISE Finance Manager, Maristops Uganda.
Good morning, everyone. My name is David Kamu. I work as a team coordinator at Maristops.
Thank you very much.
Good morning, everyone. My name is Joshua Mirondo, and I work with Communications and Advocacy Department at Maristops Uganda. Thank you so much.
Good morning, ladies and gentlemen. My name is Arini Twesandra. I work with Maristops in the Communications and Advocacy Department. Thank you. Good morning, everyone. My name is Suzanne Obalim. I work with Maristops Uganda as the SPC Coordinator for Midwestern Region.
Thank you very much. We have covered all corners, and I'll check for teams that I haven't recognized, I think who came in a bit later. And yes, please, Dr. Gizamba is here. If you haven't introduced yourself, please let me pick you quickly and then we can begin.
Thank you, Rita. Good morning, everyone. You're welcome. My name is Robert Gizamba. I'm the Finance Director of Maristops.
Good morning. Nice to see you all. My name is Ronald Ahirire. I'm the Country Director, Population Media Center, and we were a partner on the SBCC component on the RISE program. Thank you.
Good morning, everyone. You're most welcome. I'm called Irene Among. I work with Maristops. I lead the contact center. So basically here is our exhibition table, we have our products. We have our IEC materials, the cards, the brochures, the bumpers. Then we have our annual report. So please feel free to pass by and have a copy of yourself. Thank you so much and have a lovely day.
Thank you very much, Irene. And you're all most welcome once again. For all of you that we saw when we had our regional engagements, starting with the West Nile team. Colleagues from West Nile, please by show of hands. We've had several districts. Thank you very much for that long journey. And the team from Karamoja. And Dr. Migai, when you are aware, I said I have another name called Awole. So that you had. Okay, so you're most welcome, sir. The team from Eastern, do we have any colleagues who've traveled from East? Central, and the team from Central, Wakiso, Masaka, Lwengo, Rakai. Okay. The Western region, Fort Portal, Chenjojo, Bunyangabo, Kasese. Thank you. You're all very most welcome. We met most of you when we had the regional closeout meetings last month. And the team from Kampala with your traffic jam and potholes that has taken you 3 hours to arrive. You're most welcome, colleagues, in this place. So on your tables, you have table talkers, which have both the program, but also summary of the RISE program. So please use your phone to scan and get the program, which we are also showcasing now, but for later on. You have on one side this, which says can't read fact sheet, and on the other side, scan for the event program. So if you can use your phone to scan, if you're using an Android phone, you need a scanner app. You point it there and it will read it and there will be a link. If you're using an iPhone, use your usual camera and it will give you the link. Please click on that link and then you have the program. And we have IT colleagues who can support those of you who are not able to get that. But we'll go through the program as well for your comfort as well. So we have completed 2 items and we just completed opening prayer and introductions. We will have welcome remarks and then a presentation of the RISE program. And then a bit of success stories and videos which will play all throughout the event. And then we'll have a bit of learning from the PMA team, evidence on informed FP programming and addressing inequity. And then we'll have a question and answer. We will later on have remarks from UNFPA on general reflections on the HRS space and progress that's been made with emphasis on the FP 2030. And thereafter, we'll have remarks from the British High Commission and our chief guest who will come in at a later point to also give us remarks. And finally, we will have some merit awards to give for the performance across the regions and impacts that we've seen over the past 6 years on RISE. So you're most welcome once again. And please feel at home. We have teas. Those of you who had tea, I think tea is now done, but there is water on your tables and there are some mints. And then we'll be going on with our program. I would like to acknowledge in a special way, a few guests who, again, we'll introduce later on. But we have a Medistas, the Development Director from the British High Commission. Mr. Philip is here with us. The Honourable Member of Parliament and our outgoing Chair of the Health Committee, who we've worked very well, Honourable Dr. Charles Ayume is here with us. And the colleagues from Ministry of Health, Dr. Mugahi, who's here. Dr. Rachel had already introduced herself, but she's also here, Dr. Rachel Beagia. Our Senior Country Director, MSI Africa, Dr. Carol Sechimpi, will be coming shortly and we'll introduce her at that point. And the RISE team, and also in particular our team leader, Dr. Peter Dungu, and also Deputy Country Director, Mary Stopes. You're most welcome. Without further ado, I would like to go to our next agenda item, which is remarks from, welcome remarks from MSI, colleague, Dr. Karo Sechimpi, Senior Director, Africa, to give us welcome remarks. Thank you very much.
Your Excellencies, distinguished guests, ladies and gentlemen, all protocol observed, good morning. We serve breakfast. Good morning. On behalf of MSI UK and on behalf of Mary Stopes Uganda and on my own behalf, it is with great pleasure and a deep sense of accomplishment that I welcome you to this occasion where we are going through a learning event and a transition event for RISE. This gathering marks a culmination of almost 6 years of hard work, of partnership, of collaboration, of learning for the well-being of Ugandans. Back in the day when we started out, about 2016, when our MSI's main intervention in the public sector was outreach, mobile outreach, I remember having a conversation with my team where I said to them, please greet. When you go to a public health facility, greet the gatekeeper, greet the in-charge, greet the nurse, greet the stores keeper before you start doing your service delivery. And I'm really amazed to see that 6 years later, this greeting has culminated into mentorship, into skills transfer, into deep partnerships in line with our public health strengthening program. No wonder the UDHS of 2022 reported a 3 percentage point increase in modern contraceptive prevalence rate. Now, 3% sounds like a small number, but it is not. For a population that is as young as ours, where every year you have multitudes turning of reproductive age, it takes a concerted effort at all levels to be able to achieve that. And while we acknowledge that there are regional variations and stubborn problems like teenage pregnancy, I think those of us who've been part of RISE have good reasons to celebrate. I want to take a moment to recognize each one of you, our esteemed guests. Thank you for coming. I want to recognize representatives of the government of Uganda, representatives of the Ministry of Health in all your respective capacities, all the way from the minister who's not here, the permanent secretary who I expect to come. The permanent secretary of the Ministry of Health has been such a champion on RISE. Working behind the scenes, she has held this project together and ensured that it is delivered seamlessly. We've also had a champion in Dr. Charles Olaro, who's not here again. We thank him for his contribution. Each of the district health officers, each of the ADHOs, each of the service providers who've taken our mentorship, each one of you representing the government of Uganda, we welcome you and we thank you for your partnership on the RISE program. We also want to acknowledge the partnership and support of the Parliament of Uganda through the Health Committee. When we started out, we were working with Dr. Michael Kenya, and then we received Dr. Charles Ayume and his team. Thank you very much and welcome to this event. Our donors, the British High Commission, Philip, you're most welcome. There are several members of the team from the BHC who I see on this table. But I'd like to single out Grace and Arnold, who have been our partners in troubleshooting and just keeping this project on the run. This project has gone through unprecedented challenges and opportunities. Most challenges are also opportunities. Like the COVID era, 2 years of freeze, and yet we continued to deliver services. And this was because we were troubleshooting through our donors. Thank you very much and welcome to this event. Our RISE partners, members of the consortium, Rahu, our youth partner, Population Services, PTDRO, welcome. FHI 360, welcome. Options, welcome. Population Media Center. And while I was reflecting about today, I remembered our fallen colleague, Patrick Lubowa, the late, with whom we started out on RISE, and I hope each of you will take a moment to think about him and his contribution, and also our colleagues from Makerere University. Dr. Makumbi, thank you, and you're most welcome to this event. There's a saying that if you don't have reproductive health commodities, you don't have a family planning program. So I'd like to acknowledge our partners in supply chain, the national medical stores and the joint medical stores, even though they are not present in the room. I'd like to acknowledge all of the other donors. I had a representative from USAID and other implementing partners, my colleague Lillian and others who have worked with us on many forums. There are many fora where we sit and talk about SRHR, and it is that collaborative effort that has enabled us to be able to deliver RISE. Last, but by all means not least, I'd like to invite you to join me and put your hands together for our RISE team leader, Dr. Peter. Dr. Peter has given us farm leadership through this project. Normally at MSI, we would fly in an expatriate to do a job like this, yeah? But Peter, who's our own board and bred here, has done it. And Peter, we acknowledge you and thank you. Congratulations on RISE. The next presentations are going to delve into the technical matters of RISE and the learnings therein. But for me, from where I sit overall, RISE has been a great success. The British High Commission has scored us A+ each time they come to check in terms of our delivery against KPIs. But more importantly for me is the partnerships that we have built, the skills base that we have built, and the movement of Ugandans at all levels whom we have recruited. Ugandans who understand that enabling women to choose the number and timing of their births not only saves lives, but is also a cornerstone to national development. As such, while we're closing the chapter on RISE, I'm really not anxious about the future. In fact, I'm excited. I'm excited about what next, who next, with who next, we do more for our country. Once again, I thank you all for joining us at this event, and I invite you to enjoy the rest of the program. Thank you very much.
Thank you very much, Dr. Carol Sachimpi, who we started with as our country director, Maristops, at the beginning of RISE, and then to senior country director, looking after several countries, and now our MSI director for Africa. So thank you very much for those remarks. And another hand clap for Dr. Carol. Would like to acknowledge the presence of Dr. Kamara Nicholas, who's been delegated for the incoming chair of the Parliamentary Health Committee. But we've also worked with Dr. Kamara in his capacity across RISE in advocacy areas. So very good to see you, Dr. Kamara. I would like to now, as we wait for the next presentation from the RISE team leader, acknowledge and request that each of the RISE consortium partners stand up for this recognition. And I'll ask you to come here as Dr. Peter prepares his presentation. RISE has been an adaptive program starting in 2018. Delivered through a consortium led by Maristops. And Dr. Peter is going to take us through that. But alongside those partners, would like to recognize, first of all, the RISE core team. Dr. Peter has already been recognized, but I would like to recognize Mr. James Kasuja, our RISE finance manager, who's kept us afloat across the very complex contract, a performance-based contract that has fees, that has KPIs, but make sure that we are reporting correctly across the consortium. You're welcome, James. I would like to also acknowledge now the partners. I'll start with Population Media Center. Mr. Ronald Ahirire is a country representative for Population Media Center. Please come forward. And they delivered a very innovative program, Sotakai and Akakunizo, the first of their kind, which was radio serial dramas in English and in Luganda. They're available on YouTube, so courtesy of the RISE program, they've been able to make them available even after the program. They're very educative. They span the entire SRH scope, GBV, etc., in an edutainment format. So thank you very much for coming, Ronald Ahilire. And then I will pick FHI 360. I don't know if, Douglas is here. We had also been expecting Dr. Nathan to come, but Douglas Nsibambi. FHI 360 have been on RISE, our SBCC technical assistance, providing and leading on interventions that are around behavior change and what are the things we should be doing and adapting each year. So you're most welcome, Douglas Nsibambi. And then we'll have Makerere School of Public Health, Professor Naz, I've seen you walk in, who have led our RISE research and learning, all the way from the formative research, the resource mapping that determined where we're going to go in terms of regions, to baseline, midline, and endline surveys, and making sure we're actually doing interventions where we need for equity. So thank you very much, Professor Naz, and he was alongside Professor Makumbi as well, who's also from PMA, and he's here. I will then pick Reach a Hand Uganda, who are a youth partner, but also the partner for whom were mandated to build capacity to grow as an organization on RISE. So as they were delivering work in terms of the scope for young people and interventions for young people, MSI was mandated to also make sure their systems at the back are more sound, and we've seen them grow to the improvement. So Benson is representing Reach a Hand Uganda, and he's a program manager. Head of programs. And then later on, we got added or started working on the advocacy component in 2021, and two partners, Options Consultancy. Mr. Walakia David is here, if you can please come up. And these colleagues were supporting subnational accountability mechanisms, but also advocacy at subnational levels, and they were mandated to support rapid engagements in 15 priority districts, Mr. David Walakia. And then PPDR, Patrick is here. They supported a significant amount of work on the advocacy at the national level, but also building capacity of civil society organizations within the RAMNAC platform to advocate beyond the big partners that we have here. And they built capacity nationwide, doing trainings for civil society in all the regions, but also at national level. We had the dance between the SRH policy, the ADH policy, and then health policy. We had a bit of a dance and working really hard around the National Health Insurance Bill, and they were leading on RISE with that and working with the Parliamentary Health Committee and most of you colleagues here. So I will invite the RISE team leader, Dr. Peter Dungu, to say a few remarks and acknowledge these colleagues, and then afterwards we'll sit down. But thank you so much. So these here represent the different entities, 6 entities, who have delivered RISE alongside the Maristops group. Maristops team led the consortium, and these provided particular expertise and additional support to make RISE what it is. So as Dr. Peter goes through what we have achieved, For each of those indicators, I thought it is important for you to know the partners that we've worked with to be able to deliver this work. Over to you, Peter.
Thank you very much, Rita. I will say a few words shortly about Rita, but building on Dr. Carroll's protocol, good morning, ladies and gentlemen. Thank you very much for coming. The team here, as Dr. Rita has introduced, I would just like to assure you we've had a lot of support from you guys. There's been a lot of innovation in the RISE program because of the consortium partners we've had. And so whatever we'll share very shortly, please understand that Maristofs hasn't done this alone, but we've had a very strong team with us. So thank you very much. And it's been a pleasure working together. You may please take your seats. Rita introduced everyone on the RISE team within Maristofs except herself. Rita works as the senior program manager for RISE, but is actually our head of grants. And she's really been the muscle behind RISE. You know, the detailed thinking, the implementation plan tracking, pulling things together. RISE as a performance-based contract is a very complicated way of calculating results and how you'll get paid. And so Rita has been at the back of all that. As you heard, we had a lot of ups and downs. COVID led to a few hiccups and we had to rethink. And at the back of that, we've always had to pivot and think. And Rita has been, you know, behind the scenes pulling all of us together. And so, Rita, thank you very much. Job well done. And it shows this morning. So whatever you see that is good is Rita and the whole team behind her. We also have people who are not here because we could not bring everybody from Maristofs. The people who support the team you've seen today, some of whom are outside at the registration tables. We also want to acknowledge all our internal teams in service delivery and the other things. Right, so we are running behind time. I will try and run through the next presentation, which is about our results. So if you just... there you go. Okay, brilliant. So I'll go to bed tonight having learned one more thing. I'll be a better person. Right, Rita has mentioned a lot of the information on this slide. That money was a little bit less than that at the beginning, about 26, I think, £1 million. But we've been fortunate to have cost extensions as well. RISE was supposed to end in December last year. And yes, we thank the British High Commission for making this funding available, but also for, you know, giving us the consideration to close in August. So this month, this program will be done. Now, the intended impact in the design of this program was to reduce maternal mortality. And this would be done through, you know, increasing uptake of modern contraception. And it is very pleasing in a country like ours to firmly have something to address maternal mortality. And of course, increasing the uptake of modern contraception, which, as we all know, is the first pillar of the 6 pillars of safe motherhood, family planning. And it was hoped that we would achieve this working through 5 outputs. One of the things I'm very grateful for is that as part of writing our proposal for RISE. So it's very pleasing when you sit and write things on paper, and then you implement them, and then you begin to see some of the results, as we'll see later. But in output 1, we knew we had to work around awareness of the benefits of family planning. Output 2 looked at producing actual services to increase the availability of the modern methods of contraception, and this through not only the public sector but also the private sector. Rita mentioned about commodity supply, so we didn't work alone. We knew we'd have to work with other people on that as well. And we know there's an environment around, the provision of these services. So that too has been part of this program. And output 5 looked at the data. Family planning data when we started was terribly patchy, really way behind where, for example, HIV data is. Those of you who sit on the family planning technical working group will know about 2-3 years back, we had to sit together and say, but we need to do something a little bit extra around the quality of our meetings, what we are tracking, can we agree on a few indicators? So it's not been something we're doing alone as RISE, but within the sector it was felt there's something we need to do around our data. I will skip the consortium and its management because that has been already spoken to. Now, when RISE was awarded, it was initially, when we wrote the proposal, it was to cover 6 regions out of the 10 then. Of course, the UBOS regions are slightly different, but 6 out of 10 was the initial thinking that RISE would cover. So whatever you see as white was not part of RISE. So the regions that are white have not been part of RISE. But that's not to say FCDO did not have funding in the country supporting those regions. For instance, over the same period of time, we had the WISH or WISH 2 program as well, and I've seen maybe IPPF or Reproductive Health Uganda is not in the house, but I know, for instance, SANU on DMI was part of that consortium. So WISH was implementing in also with FCDO money in some of the other regions. Now the difference in the colors speaks to the depth of the implementation of the initiatives that were being supported. But I want to make a comment. We had to do a resource mapping and an assessment at the beginning. And we then realized that West Nile, which was not initially part of the program, did need support, and it was brought onto RISE. West Nile was initially not a region identified for RISE. And I would like to acknowledge Dr. Rita Wadimba, who was our senior responsibility officer then, because she was stewarding over these decision makings, where we should go, where we should implement, what we should do where. Now, the purple and dark purple is where you had all the interventions. So we were working to support the public sector, the private sector. We're doing SBCC work. And some of our partners, the specialized reaching out to adolescents. That's the deep purple and the purple. Now, the very light purple is where we only had outreach and social franchise, mostly Eastern Uganda. And we did not do public sector strengthening work there because we were overlapping with the WISH program. So again, one of the things we've, experienced during this implementation is adaptive programming, where you say, okay, resources are better spent with that partner. And so in Eastern Uganda, you will see we did not do the public sector strengthening mentorship. All we did, and then had to, leave that to RHU and IPPF. I would like to talk a little bit about the work that Options and PPDRO worked on, but probably I'll do that on another slide coming up. So I've talked about the interventions. So let's look at the public sector strengthening work, which we did in 42 districts, where we had up to 325 public health facilities, just over 750 health workers, under a comprehensive on-job mentorship. And the beauty of that mentorship is that it is not delivered by Maristop's staff alone, because at the beginning we realized that it was important to recreate people like Maristop's in the district pool to continue the training. So we are particularly pleased that you've seen ADHOs. Every ADHO you see in this hall has the clinical skills to provide a long-acting reversible contraceptive method. They can insert an implant, an IUD, they can remove them, they can supervise the people, because they had to be taken through a TOT. Every ADHO in these 42 districts had an additional 2 people we call district trainers who went through this training. And then alongside our Maristop's regional training officer, we could then go down to the facility level to do a need-based on-job mentorship. So I wish the PS was in the room, because long before there was a concern about hotel-based training, we knew under RISE that we had to do the training on job in the facilities. And so even as we, as Maristop's, end this, we know that in each district there is the capacity to do what we do. The capacity to train health workers is there. The other channel we use for service delivery is we had 20 outreach teams which work every day, except for public holidays and weekends, rotating through districts. Each outreach team supports about 6 or so district clusters. And we target outreach at the lowest levels, Health Center 2 and Health Center 3, because we know that the public health system does not have the numbers that are required to, provide optimal service. And when outreach goes there, we do not work alone. Again, we try and pass on skills with the midwives there. And you've had a few of them in the room. In the private sector, this British funding has helped us to run a subsidized voucher where at accredited private sector clinics, and I've seen one of them, the proprietor of Nyange Clinic is here, for 2,000 shillings, for 2,000 Uganda shillings. So a community, we would work with community-based distributors. They would identify, vulnerable people in the communities. For 2,000 shillings, the community member would take the voucher to a private sector that's accredited and redeem a service of their choice. Might be an implant, might be an injectable, might be an IUD, might be a permanent method, whatever it was. And still on that same voucher, you had 3 other visits for review and for removal of that method. So the support to the private sector through that voucher has really helped, especially to improve adolescent uptake. We had 2 types of voucher. The 2,000 shillings one is what I call the hardship voucher. And then there was a free voucher for adolescents, the under 20s. So RISE has been very impactful in reaching adolescents through the private sector because income is a barrier for particularly the young. And those 114 private clinics are in about 68 districts. We know that we've also trained people there, and that work will continue. We've worked in demand generation. Rita has talked about our work with PMC on that radio serial dramas. They ran for just under 2 years, and it helped with awareness. Moving forward, these are some of the numbers we've reached. You can see our coordinator there talking to people at work in their gardens. That's all about the door-to-door, getting the message out, whether you're using the traditional VHTs or peer VHTs or peer educators, whatever the name is, you need people going door-to-door in the community. We've reached 4.3 million individuals with SBC messages. I've talked about health workers who are mentored in the provision of these family planning services. Just over 750 of them. And the mentorship covered 3 core areas: the clinical skills, the stock management, and data management. I won't go into details, but when FCDO would score us every year, there was an objective way of assessing the clinical skills and assessing how well the data management or reporting has improved, as well as stock management. We know 2.4 million individuals have accessed contraception, and up to 5 million contraceptive services have been provided, generating up to 6.3 million couple years of protection. I just want to talk a little bit about the contraceptive service. In there, we include counseling, because good counseling is a family planning service. When you look at our method information index, one of the reasons we struggle with myths and misconceptions around family planning is how, for instance, side effects are managed. And good side effects management starts with the quality of counseling at the start. And some of the nurses here would testify what has been different when you are trained to do this well. Now, I'll run through the details because we cannot just speak words without the numbers. So I'll quickly run through how the British High Commission has been measuring our progress every year, and now at the end of project. They are called milestones. So the project milestone, for those of you in the non-FP world, those are targets. In the FP world, we don't use that language. We have milestones or projections. So we had a milestone on our impact indicator, reducing maternal mortality. And at that time, we had the 2016 baseline, you know, the 336 deaths per 100,000 live births. And so we were among the happy people when we saw that UDHS 2022 results released, indicating that maternal mortality had, you know, come down to 189 deaths per 100,000 live births. Now we know we are not the only people contributing to this. As I said, family planning is only one of the 6 pillars of safe motherhood. But we like to think we have had a lot to contribute to what this country has been able to achieve on that milestone. And so you can see that was a 43.7% reduction on the impact indicator. We had some outcome indicators, which 2 of which we have exceeded, the ones in green, and 1 of which we are still behind. We don't know where that number will be when the end of project, you know, evaluation is done. Sometime, I think, in September. I'm looking at Grace. I think sometime in September, that's when we'll have the final figures in. But the contribution to unintended pregnancies is derived from what we call an impact calculator. So the services you've provided are put into basically a modeling tool, and then one sees at probably how many unintended pregnancies will be averted. That's the correct language. So we know up to about 46% of pregnancies in this country are unintended, and that figure is higher for adolescents. So we can see what contribution the program has made. The high impact clients are adolescents, those living in poverty or multidimensional poverty, and adopters, who are people who've not used the contraceptive method for at least 3 months before taking a method. And that's the number where we are below the milestone. But like I said, we don't know where that number will be at the end of the project evaluation. Out of the awareness or SBCC indicators, the ones in green, we've been able to achieve the milestone. In other words, people reached by an SBCC message, and those reached by an actual community health worker. The one in yellow or amber is a challenge for the country. And I would like to leave that as food for thought for all of us. Because despite the high levels of universal knowledge around family planning, this indicator of intention to use in the future, and Prof. Naz, is this intention to use in the next 12 months or 6 months? Next 6 months. Thank you. That indicator is not moving nicely for the country. I think Professor Makumbi might meander in that territory in his presentation. So intention to use is something we struggle with as a country, and we need to understand our communities better and speak to whatever it is that is blocking their intention to use. If there are any programs, any funding, any follow-on, that is an area that's asking for help. In terms of service delivery, I've talked about the vouchers, outreach, public sector support, or strengthening. So we've met all those, all those milestones. However, I want to talk about that second last line. Proportion of health workers from targeted health facilities enrolled on mentorship that achieve level 1 competency. So in family planning, you're not given a generalized competency rating. The quality assurance program we run requires that you have competency per method. How you give oral contraceptives, how you give an implant, how you give an IUD, each of them has what we call non-negotiables. You must be able to pass each and every one of those non-negotiable steps. And if you do, you then become a level 1 provider. And we do this every year. And one of the things we are especially pleased about is that the district trainers and the ADHOs here now have been part of how this competency assessment is done. Because it's not enough to say, I've been doing on-job mentorship, they're fine. You must have a database that this person is assessed per method and deemed fit. Now, we were not sure when we were setting this indicator whether in the public sector you could get 85% level 1. But we've been pleasantly surprised that with adequate attention, you can get a public health worker who will provide an implant or an IUD confidently and not miss any of the key steps. So 90%, I showed you a figure of 325 workers. 90% of them are level 1 providers. And we know that they're really there because in the progress of this program implementation, as we worked in the sector together, looking at getting supplies in the right places, together with other partners, it was realized that it's okay to now include at the health center 3 level methods like implants and IUDs because they are trained people who can do the job. And that's not only RISE, but it's part of what the health sector was doing. And I would really want to thank the Family Planning Technical Working Group and all the people in there. Can we clap for yourselves? Because that's a big win. The FP kit that used to go down to health center 3 level only had orals and injectables. Now we sit in a different space. The last couple of indicators are around advocacy, and I'll speak to the district costed implementation plans, the DCIPs. So we know we have a national family planning costed implementation plan, And some districts had also DCIPs, supported by some of you partners seated in this room. What was innovative in this program was that Options had a methodology for getting a district leadership team, not just health, but the political leadership, the technical leadership, to actually pass a work plan that includes some provision for family planning. But better still, they did training with at least 3 CSOs in each district to understand the data and to understand how to advocate, to hold the districts accountable. And this has been done in 15 districts, which you can see there. I had the opportunity to sit in a training session with the Liantonde CSOs, and I was impressed because you're looking at people who are working in education, in health, looking at school dropouts, and understanding their own local data to say, I think this is what is meaningful to do for Liantonde. So our hope is that this could expand, everywhere, because it's a location planning for its own communities. I won't speak much about the policy engagement. Just for context, a lot of work was done by UNFPA. I think they're not in the house yet, or maybe, okay. Now we have someone from UNFPA. The first couple of years on RISE, UNFPA did a lot of work on the policies, the ADH, the SRHR. We now know this has been merged into the one national health policy. We've been able to get some wins on the allocation to FP commodities on vote 16. That percentage, I think, is 50%, big win. We know the communication has to start early from ministry to national medical stores before, budget cycles, but there's been movement. We've worked a lot with Parliament on not only us, but we've been part of the partners supporting the National Health Insurance Bill, and we know it is slow, but we've been part of those supporting ministry to get that through. And I'm glad someone talked about the RMNCAH plus N platform. I think it was Jackie. We've also worked closely with them, building capacity and working alongside them. I will not dwell much on this slide, but it shows by region how many health facilities have been supported. Now you'll see in East and East Central Uganda, there's a lot of not applicable because this was public sector strengthening work. But those are the numbers in terms of what has happened in each region. And where you see smaller numbers, it means that region was onboarded a bit later. Not all of them were onboarded at the same time for the public sector strengthening work. This is the last slide, and I think Dr. Caro did my job here, and Rita also did my job here. So I'll just reiterate our appreciation to the British High Commission for funding. This has been a lot of money required to do stuff. But it's not just the money, it's the thinking and the quality of holding us accountable. It's not been easy. Every quarter reports are sent in, and Arnold and Grace ask questions. They ask about these numbers and these trends. So Arnold and Grace, thank you very much. That technical oversight has helped us run a strong program. And Dr. Rita Wadimba before that was the one asking these questions. Thank you very much. They helped us run a strong program. I want to thank the Ministry of Health. Our district engagements would not be possible without the Ministry of Health. We've had every support from the PS, you know, and the whole team that serves under her. Special thanks to Dr. Mugahi. Dr. Mugahi found us along the way. RISE had already started. But Dr. Mugahi is an action junkie. He kind of does not give you time to breathe. So it is, I need this, I need that, I need this, I need that, we need to move that. And, but we've had absolute support from the ministry. We felt that support and we're really grateful, including, you know, the whole team that serves under you. We want to thank the district, local governments, the DHOs, the ADHOs, the CAOs, you know, even the LC5s. There are a lot of people who are not in the room. I have not had the experience of, or RISE has not had the experience of being chased out of a district. And it is possible. Yeah, it is possible to be chased out of a district. Or if not chased out, it's possible to be resisted. So we do not take it for granted that the districts have been willing to open doors, work with us. And where we've got things wrong, some of them have told us, that's not quite it. And so we want to really appreciate the districts for your support. And please, we may not have RISE today, but continue to open your doors, continue to work with us, continue to advise where you see us going off track. The communities we serve are not in this room. Yes, they're not in this room. But communities can also chase you out of their locations. And so the fact that we Madam PS, you're very welcome. We're very happy to see you. Fortunately, I'm finishing my remarks. Dr. Carol will find the language to package. Yes, the communities we serve are not in the house, but they are really, you can't succeed. You cannot succeed when communities are not part of what you're trying to do. And one of the, I think the challenges we have in designing follow-on programs is to make sure that there's a strong community component in creating, you know, follow-on interventions, because if it doesn't make sense to them, it will not work. I think I need to stop here. We will not thank the consortium partners or Maristop staff again, because we need to listen to the more technical stuff. Mine has been the easy one. But I want to thank everyone for enabling us to do this work. Thank you very much.
Thank you, Peter, for taking us through the performance on RISE and what we have been able to achieve. I would like to acknowledge in a special way our chief guest once again, Dr. Diana Twine, you're most welcome. RISE has been delivered on behalf of Ministry of Health, and so it is befitting that she comes and gives us or sees us through as we're closing and transitioning RISE program to look at the successes of RISE that she entrusted to Maristops to be able to deliver with funding from the British government. So thank you very much for coming, and you're most welcome, Dr. Diana. I'd also like to acknowledge additional colleagues and district teams that have arrived. The DH of Chibuku, Dr. Buyinza Godfrey. You're also most welcome. DH of Chegegwa, Dr. Mulumba. You're also most welcome. And representative from Busoga Kingdom, Veronica. You're most welcome. And the UNFPA representative, where are you, Francis? There you are. Thank you. You're most welcome. Would like to go to our next agenda, really to keep in time. It is also part of a performance. RISE was a KPI-driven contract. You had to deliver certain metrics, and value for money was high on the agenda. So part of the research and the endline work we looked at is whether we delivered on most of the indicators which Peter has presented, but there is something we're not measuring or we didn't know how to measure, and that is equity. And Professor Frederick Makumbi, you're most welcome to take us through whether we're closing the gap on inequity when we're providing SRH services and where the gaps lie in that area. Thank you very much. You're most welcome.
Yes, I think I need to. I know Dr. Peters was a little bit taller, so I have to bring it down, right? Okay, so thank you so much. I'll be quick, and good morning to you all. I tentatively listened to Dr. Peters' presentation, and I would like maybe to make a very quick summary of my understanding of the presentation. We are part of the monitoring and evaluation and research, and my team lead, Professor Nazaria, is here. But I was requested to package a few things, try to understand, importantly, that even as RISE was able to make indicators rise, the ones which are meant to be rising, not maternal mortality, which appears to also have come down based on the Department of Health Service. Those that are supposed to rise, rose. RISE project working together with other partners, and those that are meant to have come down actually came down, again, RISE working with other partners. Our research analysis here does not make an attribution to say it is RISE only. But Dr. Peter, Dr. Caruso were emphatic. The teams we are working together to make a difference of what we are seeing. So my work here has been made simple because you saw a lot of greens making their improvements in the regions, in the settings they worked. Together with other partners, I'm a teacher, so I have to be careful, not a preacher. I have to be careful so that we don't leave this place and say, RISE arose only, but it arose with other partners working together. Something very quick. Even as the changes we have observed in green occurred, were there some communities which were left behind? You may realize that according to the Department of Health Survey and the census, the total fertility rate in Uganda has come down, 5.2. But there is something very important that we don't need to lose focus on. Are there communities which still have very high total fertility, We still have high maternal mortality. We still have high MCPR and other indicators. Our work is to make sure nobody is left behind. The challenge I had for this work here was to present. I have technical people. I have people like me who are community people. So I've struggled to see how do I make sure every one of us leaves this place when we understand RISE together with our partners, made indicators RISE, and those are supposed to have calmed down. And then the question is, if there was a gap, was it closed between the rural and urban? By the even urban, you may know we have what we call the urban poor. Not everybody in Kampala is rich. The urban poor challenges that even as implementing partners work, please, we shouldn't be able to forget that as well. So I may use a bit of technical pieces here, but again, we shall be able to summarize them quickly. So my focus, together with my colleagues, I worked on putting this piece together, is to show, provide evidence beyond the numbers to show whether the gap was closed or is not closing, and we need to make sure we work around that. So next, it's supposed to be me to do that. Okay. So again, this is a summary of what I've been speaking about, closing the gap. Universal health coverage is an SDG. It is not a Makumbi thing. It's not a RISE thing. It is the Ministry of Health, planning, and everybody working together towards making sure that the gaps are closed. And so, based on the data that we were able to get from RISE project, it gave us opportunity to see whether the gaps were closing. And that's what this slide is talking about. As a teacher, I use slides to help me remind me what point I'm supposed to be managing. So I will also share these ones, pieces. And because there's so much and so many indicators that RISE was able to address, work around, but the focus that we have is going to be on modern contraceptive method use in the 7 regions, as Dr. Peter indicated. But the other indicators we could use. Modern contraceptive use here, an indicator is an outcome indicator. You should do many things, provide service and all that. But one of the outcomes that one can assess is modern contraceptive use. But then you can also go ahead and assess impact like maternal mortality and others. But we are using only one example, which kind of is a summary of many other things that the team did. And so where this animal called equity, and I'm just going to be kind of simplistic, but also being realistic, where individuals have the ability to access quality, we saw that was one of the objectives, comprehensive contraceptive information. When you talk about services for FP, you're not talking about condoms, implants, and all that. It includes information. And we usually miss out that piece. Information is extremely important. And the issue of voluntary use, voluntary receipt of the information, but also voluntary use of the methods and services. And they must be free of discrimination. Why should short people be receiving and tall people don't receive? Why should you come to the urban but not to the rural? Even when you come to the urban, why should you be going to the rich ones within the urban and leave out the other? Why do you go to the older ones and leave out the younger ones? So this is what is talking about. Don't coerce anybody. You remember in the 1960s, my understanding in India, there was a lot of coercion for FP. It shouldn't be violence. Make decisions about their fertility without variation in non-medically indicated characteristics. Don't serve people because of age, because of where they are located, because of what the language they speak, ethnicity, and many others. Refugees and also the disabled or differently abled. So that's what equity is all about. Everybody must be provided the services they need when they need them voluntarily without forcing them. So again, that's what we do here. When you talk about equity, it is not something Makumbi rose up to say or RISE or other partners or Ministry of Health. It appears in our strategic documents, which we need to monitor. And so clearly, we have the CIP2, we have the FP20 2030 commitments. He says, no, I won't be being academic here. We are being accused of being academic when you come from universities. But there are things we work together with, the program, policy, and academic to put things to make a difference in the people's lives. And that's what is key. Again, I won't bore you with this conceptual because I need to make there's a balance between the program, policy, academic, and all that. But as I indicated, don't serve people because of the dimensions, because of their age or locations. But also, as you provide a service, FP access should be equitable. Quality should be equitable. Information should be equitable. That's the top box. But then we're able to assess that even as we provide those services, when you look at impact, the total fertility decrease, maternal mortality decrease, child mortality, but some of those work through the fact that the outcomes have maybe improved. Has the demand satisfied improved, MCPR improved, and many others. So that's the detail I don't want to go into. But data from the performance monitoring for action, again, one of the research programs that we do here on a regular basis, we know, all of us know, there's been significant improvement in MCPR over time. That is extreme, I think, right, depending where you are facing or left. But we know there are many disparities. The wealthier women, or women from wealthier quintiles, tend to have lower unintended pregnancy rates than the poorer ones, which means we need to close the gap, not by making the richer women go up, but also let them continue going down in unintended pregnancy rates, but also make sure your services are also delivered to make the poorer women also tend to have lower unintended pregnancy, improve the services, including the quality and information. But we know very well in Uganda, again, the adolescent childbearing is higher in the rural than urban. So why do you go to the urban? Because it's closer for accountability. We need to go where the issues are. And I think RISE, working with other partners, has been able to address part of this problem. But a lot remains also with us. But also, this is also another famous reproductive health event, picture which you may have seen, comparing women in urban and rural area. Age at first sex begins much earlier in rural women, 16.9 compared to 17.7. So as they go through first birth, again, women in rural area begin earlier than the urban. First contraceptive use also tends to be now kind of similar, but by the time women in the rural area begin using modern contraceptives, they have about 3, I don't want to say 2.3 children because there's no point child. Yet, on average, in the urban area, they have fewer. So again, these were data that have been collected. So when you want to provide a service, why should one group be seen to be left behind compared to the other? So can we go ahead and use the evidence? So we have gone ahead to work again with the Ministry of Health. Good enough, Dr. Mugahi is here, one of the committee members of the Equity Steering Committee. We are saying we need to understand equity because in the documents, guidance, one of the important things that we saw, interestingly, the number of partners in regions varies. When you did an IP mapping, I think 2022, Dr. Mugahi, my recollection, what I recall very well, Karamoja had about 3 or 4 partners, and the Kampala as a district or as a region had very many. Don't ask me to count, but there are very many. But what this graph is amazingly showing, Karamoja as a region, even with a few partners, the partners covered 97% of the facilities. In Kampala, even with the many partners, only about 70% of facilities were covered. These are things which speak about inequities in service delivery and access. Of course, the partners are doing different things, and Dr. Dung also showed that. So we are working on trying to dig more data and understand, yes, there may be very many, but what are they delivering? demand generation, supply, health system strengthening. So we are digging into that. So, but this slide also showed us there's disproportionate availability of partners, but importantly, it's not about the number of partners, but are you able to go and engage everybody who needs what is needed. Many years ago when I was in the primary, I think I can say about over 40 years ago, in the P5, when you used to do this mathematics, X, Y, and all that, I thought I would run away from mathematics, but you can't run away from maths. These interesting graphs you see here, they have what we call a Y scale and an X scale. When you move 10 meters here, how many meters do you move by verb? When you move 3 kilometers, what distance have you covered? And a classical case, of course, is speed as one of the areas where I use these pictures. But let me explain one of these graphs. The one which has got education. On the y-axis, it shows the proportion of the population of women who are using modern contraceptives. It runs from 0 to 100%. It's cumulative. On the horizontal or x-axis, it shows the proportion of women with the increasing wealthy quintile. 0 would mean there are 0 percent of women in the lowest quintile. 100% would mean all women are in the wealthiest quintile. So moving from 0 to the extreme, I think it's called right, 100, it means everybody is. That line you see in the middle, the black one, it means when you move 1 centimeter here on the x-axis, you move 1 centimeter on the y-axis as well. Meaning, you go 1 step here, you go 1 step there. So there's equal. But the curves, the dotted lines you are seeing below, is it me or? No. Okay, it's technology, not me. Thank God. This one is fine. When you see a line, dotted line, which is below that vertical line, black line, it means the wealthier women on the extreme end are better off or have a higher proportion of use of modern contraceptive. If all the points fell on that line, it would mean, the black line, it would mean whether you are poor or whether you are rich, the use of modern contraceptive is the same. It doesn't differ. But the moment the dotted line comes below that black line, it means the poorer ones are less likely to be users compared to the richer ones. If the line was on the other way, above the black line, it would have meant the poor ones are better off. But what we need is equity, is everybody being on that black solid line. So we don't see that when you look at wealth, we don't see that when you look at education. Wealthier ones and more educated are better off, are advantaged. And this study was done based on the RISE baseline data in the 7 regions. We saw inequities or disparities in modern contraceptive use. In 2023, we conducted an end line after RISE had been out there, of course, together with many other partners working together. We are not doing attribution, but RISE contributed, was part of the game changers. What we are seeing here is the red line. The red line is running away from those dotted line, going back to that black solid line. The red line is data which were obtained at the end line survey, which Professor Nazarias led at the end of the RISE. We did another survey, end line. And we see that red line is going back to the black solid line. Yet earlier on, that blue line, dotted one, was far away from that middle line, which means there was disparities, meaning the richer ones were more advantaged in use of modern contraceptives, whether in rural or urban areas. But at the end, the red line came back. Again, this provides evidence beyond the numbers, how many we have provided with and how many we haven't provided with. It provides a bit more solid analysis and evidence. Again, toning down the terminologies and languages. So the take home, there was improvement in equity, whether you are rural, whether you are urban, whether you are poor or rich, we saw that gap closing. So in summary, we could do a lot of analysis and all that, but the take-home message, we are using modern contraceptive as an indicator of how well RISE was able to achieve what they achieved, together with other partners working in the environment where they did. So, but RISE, as you saw, crafted their deliveries, their services, information, commodities, strengthening of system and everything together. Those packages, working with the communities as they have indicated, to create targeted programmatic interventions that then we see have been able to reduce the disparities between the rich and the poor. Whether in rural or urban, those have been closing. But importantly, many of us do projects and we forget the animal called monitoring, evaluation, and learning. So never leave, because we are evidence-based, and we need, once you're evidence-based, then you'll be able to not do one size fits all. So, and this beautiful circle is telling us, go ahead and identify inequities and their drivers, design interventions, implement them in the targeted setting, and monitor and evaluate, and then you keep learning and providing better interventions. So it's very important that all the projects continue having the learning component in there. I would like to appreciate Research for Scalable Solutions, providing some of these slides. I'm engaged in that as well. Macquarie University School of Public Health and Ministry of Health, especially with the focus on the Equity Steering Committee, which is working together with School of Public Health and RFS to make sure nobody gets left behind, and we use the evidence to do programming and just don't do one size fits all. So thank you very much for listening. Over to you.
Thank you very much, Professor Makumbi. And for me, I'm very particularly pleased that FCDO used to ask us equity. As part of your value for money, how are you spending money? Where are you spending it? How many people are you reaching with that money? We had a KPI on equity. And we ran through a lot of indicators for equity. But I'm particularly pleased that the Macquarie team, with the data that we collected at the baseline, midline, and end line, was able to pick for us what that looks like. We used to use proxies. We are in Karamoja. We are looking at this, reaching this number of adolescents, which is equity in itself, but it doesn't give you an objective measure on whether you're reducing the disparities. And I'm really, really glad to see that this work we have delivered has started that journey, and to implore all the IPs here to think about equitable access beyond just the number of adolescents you've served. How are you reaching them, and do they have equal opportunity for services? So thank you very much for that presentation. The paper is going to be published as a series of papers that Professor Naz and team are led. We also have published papers from this work, from the baseline and midline already in BMC, etc., and we'll give you some links. I would like to now acknowledge additional guests, particularly the religious leaders, Reverend Nathan Mugalu, and Reverend Evat Mugarura. You're most welcome. And Sheikh Semaweje Nasa, you're also the Muslim champion. We would like to take a short break for tea. I'll ask Nasa, please, to give us a prayer for our tea. It will be a working tea, so we'll ask to serve, and then we can continue. Just cognizant of the people who have traveled from very far, all those of you who are stuck in traffic jam for 3 hours this morning, so you can have a tea break. But it's going to be a working tea. And we have 2 serving stations, one on my right and the other on the left. And again, an announcement for the washrooms. They are on the first turn on the left. As soon as you get out of that door, you walk all the way down the corridor. You see the queens and kings there opposite each other. So let's have a quick prayer for the tea. And as we're having tea, summarized material will be played from the regional meetings and some of the beneficiary stories as well. A quick prayer, thank you.
Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanirrahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina siratal mustaqim. Siratal ladhina an'amta alayhim. Ghayril maghdubi alayhim waladdallin. Amin.
We all say amen or amen. Thank you very much. So I'll ask you to have tea. We're going to take exactly 10 minutes to serve, and then we'll be back. Dr. Kara, if you can take the guests for tea. Please get up for tea.
So today we are celebrating 7 years of a partnership between the British government, the government of Uganda, Maristopes and the consortium members.
So the major emphasis of this meeting is specifically to look at the performance for the different family planning indicators, and this will be based on the HMIS reports. For Bulisa, 24% we reduced to 23. Then Kagadi from 22 to 21%, good. Then Kakumile also registered the reduction. Then Kibale also registered the reduction.
We have some things, and we're going to listen to stories today on the frontliners who have been doing some of the work for us to appreciate the so much, okay? And maybe when we can learn from those stories today, we can now ask each of ourselves as districts, what can we take from the things that are working, the things that are sustainable from this program?
Kati nze mu baana 10 benina nayambibwa okuba nti songeddeko ki abalala mu myaka gino nensobola okufuna obusobozi obw'okuba nti sina gwe mpadde lubuto mulala agenda kumanja leeta obukoye leeta ndi lubuto simebiki esente zo nenziteeka ku baana bange kyekirungi kyenfunyemu. Saawa zino nze nina abaana omwaka ogwo bamaze siniya 4 babiri, nina omwana omukulu ayamala siniya 6, nina abaana bayingidde siniya 2 bameka babiri, abalongo bali mu P5 saawa zino. Nsobola okwewanirira saawa zino okusinziira we nali.
We first saw them to the idea, what is family planning? How does it align to the priorities of this country? So when every one of them was convinced beyond reasonable doubt, we didn't need any more convincing. They knew this is something, if we are to develop as Kalum district, if we are to move from where we are to another level, we actually need family planning to be prioritized.
The challenge that we went through as children. My dad had 28 children from 4 women. So from the experience that we went through as a family, the struggles, my dad was a soldier and my mom was a housewife. From the struggles that we went through, when I got 3 children with my wedded wife, whom I graduated with from Makerere, I chose to do vasectomy.
I'm happy to see that some of these footprints that we've left are ongoing. And I think that is the essence of today. We just want to say, how are you ready to take on this mantle? But at least we are happy. This has been ongoing. It will be very upset for somebody to come and attend only to know that we are giving away a new bear holder when they didn't know where we started from.
We are proud of this program for all of these events and things that they've done. We have seen tremendous results. I want to move a vote of thanks first to the frontline health workers who day and night are doing this work. Please clap for yourselves. So we want to also thank the different leaders who are here today. Then we want to thank Maristopes and the different partners. We also want to move a vote of thanks to religious and cultural leaders, even if they are not here.
such a rush, my baby, slow down, come find your love. I'm hoping you see me, come serve it up. Loving when you stir it up, that body belong on TV. Oh, this feeling I can't hide. You're feeling up my mind, and I just don't know why.
In the interest of time, I hope you all have a drink or a bite, some snacks or fruit of your choice. I would like to continue with our program for the day. And again, to remind you that the program is on your desks. You just need to scan those codes and you're able to see the program, but also the RISE summary or fact sheet on performance is also available on each of your desks. So please use those table talkers to scan and be able to know the performance of the program over the past nearly 6 years. Please help yourselves to coffees and teas and fruit. And we'll start our next session. And we're going to go towards the last half of of today's event. And it is a RISE National Learning and Transition event. The RISE program, RISE is a very long acronym, reducing high fertility rates and improving sexual reproductive health outcomes in Uganda. And it started on 1st of November 2018. It's very long. That's why we've just kept the RISE program at the top. But that is the intention, to see reduction in those high, critical impact areas, fertility rate and improving sexual reproductive health outcomes in Uganda. It is funded by the UK government with funding from the British people, which has also moved in terms of naming from DFID when we started. So colleagues, especially some district people who remember, were talking about DFID or DFID to UK Aid and then FCDO. And for now, we're using the new logo, UK International Development, to show that this is development aid that is from the British government. And our next agenda items, we are skipping one agenda item because of the repetition. The last two presentations have given us a bit of overview on what we have. RISE was covering 7 out of 10 regions. So most of those presentations and impact really runs through the national level impact as well, because of the footprint, 86 districts, and that is if you're not counting cities. So all the cities in those districts are also counted. So I'd like to go to our next agenda item, which are remarks from the outgoing chair of the Parliamentary Health Committee. And we particularly requested for his presence because of the journey we've walked with him, and him holding our hand, and our partners, PPDR, etc. So let us please give a hand clap for Honorable Dr. Charles Ayume as he gives his remarks.
Thank you, Rita. Our guest of honor, the Permanent Secretary, Minister of Health, Dr. Diana Twine, the representative from the British High Commission, Mr. Philip Smith, the heads of the various organizations in your distinguished capacities, Dr. Karose Chimpi, the outgoing country director and director for now MSI in charge of Africa, representatives from the districts, distinguished ladies and gentlemen, good morning. It's an honor to be here. Like I was introduced, chairman for the Health Committee Emeritus, but as a person from the health space, I still am passionate about the health sector. I moved to the Finance Committee by choice because I think we need more finances for the health sector. So I am still going there as a spy for the health sector, but also to advocate for the health sector. Well, it's an honor to be here once again to talk about the RISE project I will not go into the statistics. A lot has been given by my colleagues from academia, from Makerere. Parliament has been quite supportive in this journey. Unlike we have said and has been spoken by previous speakers that it is not only a Maristopes issue, but there have been very many players. And from where I sit, from the policy side, you're looking at family planning, but to achieve this, we also look at human resources for health, which I think we have done well, Madam PS. The enhancements across the board. You cannot achieve a number of these indicators when you're flogging a very disgruntled health workforce. So 3 years ago, we did the enhancement, and I think we have put that issue to rest. The health workers are more motivated than ever. We have infrastructure. I think we are doing quite well on that. Policy, a few issues to do with governance, commodities, health commodities. I think we're also doing much better with the last mile delivery. There are a few stockouts here and there, but I think together with the Ministry of Health, government is trying all its best to address a number of these issues. As a member of Parliament and outgoing chair of the Health Committee, I'm very happy when the UDHS results were released. And getting that maternal mortality from 333 to 189, I think is a reason to celebrate, and among the best in the region. My humble request is, how do we hold that ground? We may celebrate, but at the next UDHS survey, it could still go up. So how do we, my challenge to the ministry, everybody, government, parliament, is how do we hold that ground? And then how do we take it down further? As a Committee of Health, we tried to advocate. There are a number of things, the ambulances, which we had scored, and for some strange reason, decisions were reversed, and the 80 ambulances that we thought we were going to procure this financial year, for some strange reason, will not come to realization. But we shall live to fight another financial year. Now, we might be smiling with these very important statistics, but as the RICE project exits, how do we sustain the good deeds of this project? And how do we integrate it into the mainstream healthcare system so that we can keep on bringing these wonderful achievements further down? The outputs of the RICE program were highlighted, but I would like to tease out two fundamental ones that I thought stick out in my opinion, and that was increased awareness and data. Most of the data on SRIH and family planning some years back was scanty, and even that was there, you could not really rely on it. It was not very authentic. But I am happy that it's one of the indicators that you are trying to tease out, and with better data, we can plan better. Secondly, the issue of awareness. There are a number of myths surrounding family planning, especially in the rural areas, and that needs to be tackled. How do we package the right information for family planning? Because whenever you ask people about family planning, they may think the first answer is, I don't use contraceptives, but family planning is beyond the use of contraceptive. There are so many other facets that speak to family planning. So how do we package that information better? And I'm shy to say that even in Parliament where I sit, there are a number of people who have myths about family planning, and I'm not shy to say this. About Maulire, this one, please don't put it out there. But you sit down with a colleague and they think contraceptives are devices brought by the Western world to stifle the growth of the black race. And that's a colleague. You have to appreciate the way he thinks and try and convince him to come to your side. Because when I went to Parliament, there's a difference between common sense and politics. So much as you may have the scientific evidence, you have to, in Swahili they call it, you know, when you're courting a lady, you have to bring her slowly. You don't use a lot of force. So that is somebody's thinking, that is ideology, and you have to respect it. So how do we package that information better? The opportunities that are out there, we have about 11 million children in school, primary. But at the end of secondary, they're about 2.9. Now, the school health policy, we need to find a way of how do we package some information. As a leader on my campaign trail, it was so common to find adolescent girls who didn't know about the menstrual cycle. And you ask them every Christmas when I'm in my constituency, I go to congratulate those who have given birth. And you can tell these are minors, but of course when you ask them their age, they'll tell you 22, 23, but you can tell from the physical appearance that 16, 17 years of age. And when you interrogate further, they'll tell you they didn't know what to do after their first encounter. Most of them could have gotten pregnant after their first encounter, which shows there's a huge gap on knowledge, just basic biology. And somebody says, I didn't know I missed my period first month, second month, third month, until my auntie saw my stomach swelling, and you know, that's when they examined me locally and I knew I was pregnant. So the PS, how do we cross over to our colleagues in Ministry of Education? Unfortunately, the Minister of Education, like I said, is not somebody you can summon to Parliament, but we are ready to stand behind you, Madam PS, in the line, and we walk to Ministry of Education to put some of these things, because we have to work together. This family planning is a cross-cutting issue. It cannot be left to the health sector alone. And on the side of Parliament, I'm very happy that now we have a parliamentary forum on maternal health, on teenage pregnancies. So I think this is an avenue that we can tap into. It was launched 2 months ago by the Right Honourable Speaker. I think Parliament is now becoming more and more deliberate on the issue of teenage pregnancies. And like I said, can we every quarter post this on our dashboard by district? It's, I don't want to say name and shame, but I think it will evoke the spirits within us when you see Koboko district, Chirihura district, you know, flashing on our dashboards, because we have screens in the corridors of Parliament in terms of the number of teenage pregnancies, and it will influence policy, but also most importantly, resource allocation. What we give, I think, is a paltry $5 million, but we can give more. As I conclude, I would like to thank the UK government. These figures, £28 million, is not small money. Thank you very much. 2 years ago, we hosted the all-parliamentary group on reproductive health, and were led by Honourable Carroll. We hosted in Parliament, we went to the Deputy Speaker, and I think it was a very good meeting. From the look on your face, Mr. Philip Smith, I can see Rise 2 in the offing. So I would like to tell the project staff of Rise 1, I know it's ending this month, but take heart. nobody is going to lose their job. Mr. Smith will come forward here and tell us when Rise 2 will take off. Thank you very much, ladies and gentlemen. And from my people of Koboko, I went to school with Dr. Carol. And you thanked her for bringing you to Serena. But behind her, I told her, make sure people of Koboko are here. So please, when you go back, you thank Dr. Charles Ayume for giving you the opportunity to come to Serena. Thank you very much, ladies and gentlemen. Allow me to take the opportunity to invite Mr. Philip Smith to come and give his remarks. Thank you.
Thank you, Dr. Charles. P.S. Dr. Diana Atwine, former chairperson of the Parliamentary Health Committee, Dr. Charles Ayume, who's just spoken very eloquently on the subject pertinent today. Government officials from different ministries, departments and agencies, district leaders and health workers, religious and cultural leaders, our programme implementing partner, Mary Stopes, Uganda and consortium partners. Ladies and gentlemen, it's a pleasure to be here this morning. My name is Philip Smith. I am the Development Director and the Head of Development Cooperation at the British High Commission here in Kampala. And today is a celebration of 6, nearly 7 years of partnership between the British government, Mary Stopes Uganda, and the government of Uganda through the Ministry of Health. Together, we have worked to ensure that women are given a choice about when to have children, and that they are provided with the knowledge and the necessary care to have those children safely. The British government's partnership with Uganda on women and girls is fundamental to our engagement here. We cannot hope to understand Uganda's development unless we see it through the eyes of women and girls. Increasing access to education, supporting family planning, combating sexual violence are all central to creating the conditions for Uganda's economic opportunity and growth, and in helping women and girls and their families to thrive. So as you know, the collaboration we are celebrating here today is the RISE programme, that very complicated acronym that's written just here. For the last 6 years, RISE, implemented through Mary Stopes Uganda, has worked across 86 districts and 7 regions in Uganda, and it's a programme which you are all familiar with, and it's the largest single geographic coverage in Uganda, and has provided up to 60% of Uganda's family planning services. Already this morning we've heard from Dr. Peter and others on how RISE has helped many in Uganda. We can clearly see how the improved access to a variety of modern contraceptive choices benefits wider society. And even more importantly, fewer women are dying during childbirth. More women are able to avoid unwanted pregnancies. Better ability to plan pregnancies can lead to less pressures in the home on families and help reduce domestic violence. Every prevented death is one less child without a mother, one more family able to contribute to the betterment of their community. And we're proud that this programme has delivered significant impact for vulnerable communities who are at higher risk of poor outcomes during birth and unintended pregnancies, for adolescents and for those living with a disability. Ladies and gentlemen, I saw those positive impacts firsthand in Rukungiri district last year with Mary Stopes when I met community leaders, health professionals, and religious leaders. They told me about the difference that RISE had made in their community. They told me that they wanted those services continued. I saw how they worked with the health centre, providing maternal and child health services to ensure that it graduated from Mary Stopes Uganda support and is now transferring skills to others and undertaking community outreach. I also visited Maramba Hills in southwestern Uganda and was impressed by how our support is being used to deliver services to the most disadvantaged people in the most hard-to-reach areas of this country. We believe in tackling inequality in access to healthcare, and seeing this firsthand and the impacts of the RISE programme was reassuring. Ladies and gentlemen, Madam PS, having seen the work on the ground and hearing the conversations today, I want to give my thanks firstly to the Government of Uganda, particularly the Ministry of Health, for the partnership we've enjoyed in delivering the RISE programme. I want to thank the health workers at the front line who embraced the programme, the training, and continued providing services in their communities. Their continued efforts go a long way to ensuring the sustainability of the achievements we have proudly displayed here today. I want to thank district and community leadership which has enabled these results to be achieved. I want to thank the religious and cultural leaders who provide wise counsel to young girls and young women. I want to thank the RISE programme implementers, Mary Stopes Uganda, Carol, Dr. Peter and the whole team, and the consortium partners here today who implemented the programme with diligence and perseverance to the end. And I want to thank the women and girls, the men and boys who have engaged in the programme. What's been achieved through the RISE consortium and collaboration is significant, and the impact goes much wider. Family planning contributes to growth, to Uganda's National Development Plan, and to the attainment of the Sustainable Development Goals, all of which supports Uganda to prosper. But whilst we've seen progress, we for example, in the reduction of the maternal mortality rate, there is still more to be done, notably in addressing teenage pregnancy, which impacts 24% of teenage girls in Uganda before the age of 18 years old. We must not lose sight of the fact that Uganda has the highest rates of teenage pregnancy across the world, and Dr. Ayume articulated this very well just a few moments ago. Ensuring women and girls are supported to reach their full potential is one of the highest priorities for the British government here in Uganda, and we remain committed to continuing to work with you on issues of maternal mortality, maternal health and family planning. Dr. Charles asked me about RISE 2. Well, it's not called RISE, but it's called Empower. Following RISE, the British High Commission will work with the government on a new maternal health programme called Empower, empowering women for better reproductive health outcomes. Working with the Ministry, thank you. Working with the Ministry of Health, or continuing to work with the Ministry of Health, this will draw on lessons and experiences of family planning and maternal health interventions that we have supported today, including RISE, WISH, our global programme, and other family planning and maternal health programmes. So thank you for your discussions here today and during the regional closeout events where your achievements, your learnings, your insights from the RISE programme were shared. These are being built into the new Empower programme, RISE 2. Both of these programmes are part of the UK's wider commitments to the health sector here in Uganda, from contributing to the Reproductive Health Supplies Programme, supporting pandemic preparedness and disease outbreaks, to our support through the global health funds and the vast range of health research partnerships between our two countries. So in conclusion, let me say that the UK remains a long-standing friend of Uganda. We continue to deepen the partnership and people-to-people relationships between our two countries. Our continuing partnership on maternal and child health is a demonstration of this. We look forward to continuing our collaboration to empower women to educate girls, to meet health needs, to create jobs and economic growth, and to build the resilience of the most vulnerable Ugandans. Thank you very much.
Thank you very much, Mr. Philip Smith, and for confirming that Rise to Empower is also soon to be awarded. And we're glad that Rise is informing part of the aspirations of Empower. I would like now to invite Dr. Carol Sechimpi, Senior Director, MSI Africa, to invite our chief guest.
I am deeply honored to be inviting our Permanent Secretary for the Ministry of Health, Dr. Diana Atwine, to speak to us. Before she comes, I want to highlight my experience being led by her. I think Dr. Diana joined the Ministry of Health when I was in about 2 years working with Mary Stopes. She summoned me to her office and asked exactly what we were doing, how we are complying, and where we're going. And I explained. From there on, Dr. Atwine has been a supporter. She's the government official you're not afraid to go to as long as you're telling the truth and doing the right thing. She's big on accountability. She's not afraid to tackle SRHR. Lately, I see that she's the champion for the issue of teenage pregnancy in rooms where we cannot get. We are really privileged to be led by you, Dr. Atwine, and I welcome you to address us. Thank you very much.
Good morning, everyone. Carol, thank you for pumping me up. I'm feeling very nice, you know. That introduction was very, very good. Honorable MP, Dr. Charles Sayume, a great friend of health, a health worker, a passionate MP for health. I want to welcome you so much. Thank you so much. Even when you're in finance, I don't think we are going to spare you. We shall be calling you. Mr. Philip Smith, the representative of UK government and entire UK international development, senior officials from the Ministry of Health, entire management of Mary Stopes, the cultural leaders and religious leaders, partners in the room. I apologize, I came late, so I don't know who is in the room and who is not. I see WHO and Chai and so many other, but allow me in the interest of time to appreciate all of you for coming today and being part of this program, RISE, when we are reviewing the journey that RISE has made and the contribution that it has made, but also reflecting on the next move that we are going to take as a country, as partners, in this space of reproductive health. As you all know, and I believe before I came you must have heard the statistics, Uganda is one of the fastest growing countries. The very high population rise. Every year we add, our deliveries alone in our facilities, we have more than 1 million babies per year. Now, when you add those that are delivered in, outside the facilities. I do believe that the statistics could even be more than what we have in the last census. So that calls for a serious discussion of all players. The population is good, but the population must increase at the pace of the resource availability. Otherwise, we see so many people going on the negative side of the curve. So, in the last UADHS, although we have made great strides, where we see the use of contraceptives has increased. In 2016, we were at 35%. In 2022, it rose to 38%. But still you see that that is suboptimal. We are still at suboptimal coverage. Maybe now it could be possible at 40% if we have really made a lot of strides, but we need the recent data. And this is the reason why we are seeing our population, when you look at the pyramid of our population, a huge number of citizens of this country lie below 30%, over 50% are below. And that is quite, it has a good side, but also it has a big challenge, because this is not a productive population that is contributing to economy. This is a consumptive population. And that puts us in an awkward situation, especially in health. And now I'm talking about health services, because that's when you'll see overcrowding of mothers scampering around the facilities that we have to deliver. That's why we see people running out of space and even getting to even flow cases. That's why you see even small facilities as health center tools that are not in the service standards, they are not supposed to be delivering, women are delivering because of the pressure of the population on existing facilities. Government for the last 4 years has upgraded health center twos to health center threes. I think we have over now 400 health center threes that we have constructed, and we have brought nearer the services to the people. However, because of that mismatch, still we see a lot of pressure on our facilities. And therefore, this is something that is not just even on medical, but also social, and all other aspects of planning as a country. You have heard today in the statistics, I believe, that I think even when I was here, I saw Dr. Makombi presenting, we are seeing rural girls are more at risk than the urban young ladies. Maybe in urban, there are so many other activities, but also maybe there is more control. But in rural, why it makes it unique is because there is this issue of cultural, social, but also economic factors. Many of the young ladies in the rural that are really, we are seeing coming to our facilities pregnant with unintended pregnancies is because of the social economic issues. Some of these young girls are lured into early sex because of our social and economic structure in the rural setting that is really putting these young ladies at risk. So, as we are discussing the next move, I have had empower, so we have risen and now we are empowering, right? So after rising and after, as we start to empower, our emphasis, our focus, our fulcrum should be rotating at rural. That's where we are going to create a bigger impact. And you have heard the testimony of Honorable Charles Ayume when he interacts with those rural girls. Some of them, they don't know, they are in the gray. They're just in the gray. They don't know how to handle these issues. So we really need to think, because if we are going to attain, and I'm sorry I missed the presentation where he was presenting the indicators. I hope I will get to that presentation. I really want to see how we have moved at a granular level. I want to see how, I know that UDHS gave us some statistics, but this would be also, we want to compare and see how far we've gone. Because if we are going to change the trajectory or the targets, if we are going to achieve the targets that we have planned to and the targets as in National Strategic Plan, our sector strategic plan, even specifically on reproductive health, if we are going to achieve really our indicator, we get to the targets, we must focus on adolescent girls. Because, as you know, 28.5% of adolescent girls between 15 and 19, they are engaged in active childbearing. And this is more in the rural. So it has brought us back. You know, if you have your dichotomous structure, you'll be able to get to the real core of the real issues. Girls below 19 in rural. And that our activities must focus at that. So they are contributing to really even 20% of infant mortality that we are grappling with. 20% is contributed by these young girls. And we also know that 28% of our maternal mortality is attributable to these young girls that get pregnant and their bodies cannot handle. Therefore, it is a very serious issue. And I know that we've been working with so many partners on this. But we need to see how we can speak the same language. I think that's where we want to see how we can harmonize and speak the same language. And then we also want to see what other people, other players are contributing in this. The cultural leaders, I am happy to see my friend here, Imam, who has been really working so hard. He has been a great support in this area. We want to see that these messages, for example, cultural leaders, they tend to have many functions as cultural leaders. What message have we prepared for them that is more uniform than on this side of government? So that, For example, for them, if they are looking at, dowry, these functions, anyway, I'm not going to say that they're tribes, but I know certain tribes that even they find it is okay to give away a 13-year-old as long as she's very big. There are some people who are very big, not necessarily that they are old, but as long as they are pumped in, especially that side where I come from, they are pumped in milk, and the child of 14 is like 30, and then they are like, oh, the child now is ready. But the cultural leaders, what is the message are we preparing for them to deliver at all fora of cultural meetings or cultural gathering or wedding, whatever, so that that message is constantly bombarded to the population? When it comes to religious leaders, one time I was engaging with the imams, and I was telling them that they are the people who are so privileged that they meet 5 times a day. They have their congregation 5 times a day. Now imagine if you just package that message and you talk to them every mosque, every time, every 2 hours, or I don't know how many times, but I know that they meet 5 times a day. Imagine if that message is packaged well and we get to those people. Imagine if we are able to have this message shared with schools in a manner that it is simplified, but it creates also an understanding of the risks and also giving them opportunity to make the decisions that really affect them. It is extremely important that we speak with one language, all partners in the room, in this space. We have started the discussion with Ministry of Gender and Ministry of Education. We have started this, and I want to thank UNFPA because we have been working with UNFPA to come together and to have a real discussion. And the discussion is, first, embracing family planning. Number 2, behavior change. Number 3, addressing the socio-economic factors that put these, especially the young people, into risk. So as we are celebrating the RISE achievements, Carol, we still have a long journey to go. We still have a great commission to achieve as a country. And this journey can only be walked effectively and successfully if we are able to collaborate more. When these words are very nice, especially from our side. When permanent secretary must talk about collaboration and stakeholders management, but we need real collaboration. Sit together and say, okay, we map out this country. We have looked at the statistics which Makombe presented. You saw how Kampala and some region they are faring. You have seen the equity issues. How do we address the disparity? And we know that so many partners in this space can be brought on board to be part of this journey. Because they're in the health space, and that we can achieve if we integrate. Ministry of Health now is obsessed. It is an obsession. It is obsessed with integration. So that when we go to the community, let's not just talk about one component of of health. Let's get the whole, and that's why all the partners in the space of health, even social, like even who are working with gender or education, we need to come together so that really when the team goes to Karamoja to talk about teenage pregnancy or to talk about, or maybe they go in Busoga, we want to see that whole package involving the religious leader available in that space, the cultural leaders, the local government leaders that have a voice and people listen to them. We want to see then the partners who are implementing. We come up with a one integrated work plan. When you meet the community, and I've been talking about my colleagues here, they know. Let's not just pick one little thing and we run with it. We must learn to have integrated plans. That way, you will not cause people to fatigue. After that, someone comes, another one goes, another one comes, another one goes. You deliver a whole package of information. And when we do that, first of all, we optimize resources because we don't have enough resources. Even the partners that are supporting us, I think they must be fatigued, but I don't know how, but they are still supporting us. And so we need to see how we optimize our resources so that when we have a plan and we are meeting these people, we are engaging, we are able to deliver a whole package of information. So community engagement is the cornerstone. I just want to emphasize that, and I believe my prior speakers, the prior speakers talked about this. But community engagement is the cornerstone of the mindset change, of the behavior change, of acceptability, and embracing the programs in its totality, in their totality as we present to them. So, this is Jaja now. So empower as we, Mr. Smith, as we're going to start empower. I think that the big word on the wall will be integration. Community integrated outreach. You go to talk about, family planning, you talk about immunization, because you are talking to the same woman who has come with a teenage pregnant. You are talking about nutrition, because also you want the child who is born to be healthy. You are talking about the importance of having space in the pregnancy. You are able to talk about hygiene in a home, because you want this mother who has come, who is 13-year-old, who is pregnant, you want her to space. Maybe also she is able to go back to school when she delivers you, but also bring hope. Talk about some other activities that they can do to keep them busy, or maybe go back to school. Bring in other players, education, gender. So what are you, okay, for me I've talked about health. So what are you, on this issue of social, what do we do here? And that way we will be able to transform our community. As I conclude, I want to thank the partners that have supported us in this journey. First of all, I want to thank Maristops for effective implementation of this, that we are able to achieve this. I know that as Makumbi said, there are so many other players that, they were in the basket to achieve this. But you set out your program and you achieved. You are able to deliver what you promised you are going to deliver. And we look forward to seeing more progress and more work that we are going to work with you, to collaborate with you. We want to thank UK government for continuously supporting us directly, but also indirectly through other partners like UNFPA. UNFPA, we thank you so much for the journey that we have walked together. other partners like UNICEF, like WHO, like FHI, like all the partners, really, I may not mention everyone in this room, and all other implementing partners. I want you to know that this journey that we must be intentional. We must be intentional. We will celebrate the results, but we shall celebrate more the actual transformation in the community. Thank you very much.
Yes. Thank you very much, Dr. Diana, for that powerful message. Our last part of the event is to award people and districts for their performance at regional level. We have different awards by region. Across all the 7 regions on RISE, those districts that performed a bit more than others, they embraced our mentorship, the health workers who moved that on-job mentorship and made an impact in other facilities, but also the people handling data, and they were very keen to check the data and make sure it's reported well, and the supply chain team, the medicine management teams, those who ensured facilities didn't run out of commodities, or they were looking for partners to support redistribution, etc. So we do have these awards, and we'll read out quickly by award and district, and then we'll ask for photos at regional level and handing over by our chief guest.
Okay, good afternoon. Okay, I've been requested to present the following awards to the best winners. As earlier mentioned by Dr. Peter during his presentation, that the project did very well in most indicators, and there were people who were really in the forefront in ensuring that we deliver to the best. And all district participants did very well, but of course, as usual, we always have the best. So allow me present the following categories of awards who are the best winners, and then we proceed with the next on agenda. We have the award category of a district that did very well in excellence in the provision of family planning competence based on job mentorship from West Nile. So this was taken over by Nebi Hospital. Apologies, we have justification for the reason why a district or a facility won, but because of time issues. Then this is followed by a biostat who was very excellent in improving SRH data quality improvement, still from West Nile. This is an individual made award called Adam Joffrey from Maracha district. Then we also have an award from West Nile, which is a district that is championed sustainability for competence-based leadership from SRH from West Nile. This is a big district. Then we have the best performing. You know we have been doing competence-based on job mentorship. Structures where we have been having district supporting the provision of on-job mentorship. So we have Ramiro Lois, Assistant Nursing Officer from Koboko Hospital. Next is we have a category where we have this represented excellence in family planning, supply chain management. So this has demonstrated sustainable availability of commodities in the district. And this is a Maracha district. Then we have a district that has demonstrated increase in the best increase in the modern contraceptive prevalence rate from Western Nile. This has increased from 15% in 2019 to 30% in 2027, based on data is today. That is Zongo district. Western Nile still we have the best district that has integrated reducing high teen pregnancy rate from 24% to 3% during the political period. That is the Yumbe. Then we have a private facility that has demonstrated sustainability of delivery of high quality family planning services during the RISE project. This is Koboko Rural Medical Center. So now we have moved to Karamoja region. A group photo for Western Nile region. Thank you so much. We are now moving to Uganda region. We have a health facility that has demonstrated excellence in competence-based mentorship, where we have the best provider provision of quality services. This is a provider for health centers. We have then this will be followed by the district that has demonstrated excellence in leadership, improving SRH data quality management, and this is represented by Maribor from Karenga district. Then in Karamoja still we have a district that has demonstrated championing sustainability of competence-based family planning and job mentorship, and this is Moroto district. Then on mentorship still we have the best district trainer has really demonstrated
Never pay for Wi-Fi again. Instabridge is a free app with 20 million Wi-Fi passwords all over.
So from Eastern region, we have a district that has demonstrated increase in contraceptive prevalence rate from 17% in 2018 when the project started to 38 in 2023. This is Kaliro district. This will be followed by the best district reducing pregnancy rate from 22% in 2018 to 19% in 2023. Teenage pregnancy rate in Eastern region from 26 in 2018 to 22% in 2023. That is also Chibuku district. So that is it from Eastern region. Then we are now moving to Western. After group photo. So members don't get worried why Eastern having very few representatives. RISE project didn't have public sector strengthening in the Eastern region. So that is the reason why we have those few representatives. Then going to Western region, we have a facility that demonstrated excellence in the provision of competence-based mentorship, and this facility has providers that have really demonstrated improvement in skills building, but also having really improved the quality of services, including the improved method mix. This is Somoro Health Center 3 in Bunyangabo district. Guys, you are mean with clapping. Then this will be followed by a biostat that has really supported a lot in improving data quality management. And this is Simon Mugabe from Chenjojo district. Then we also have in Western district has really demonstrated championed sustainability of competence-based mentorship, especially from the region, and this is the Bunyangabo district. That is Simon. Then this will be followed by the best district trainer in conducting competence-based mentorship from Western region. This is Bibian Joy Bira from Kasese district. Then we also have a district that has demonstrated excellence in supporting supply chain management for SRH commodities with timely submission of orders to the national warehouse, and is one of the districts that has demonstrated adequate stock throughout that support continuity of service provision. And this is the Kagadi district. Then we have a district that has also demonstrated increase in the modern contraceptive prevalence rate. It has moved from 15% in 2018 to 40% in 2023, and this is the Bulisa district.
Let us applaud Bulisa team. It's a massive feat.
Then we also have a district that has demonstrated increase also in modern contraceptive prevalence rate from the same region, and it has moved it from 13% in 2018 to 33% in 2023.
20
and this
points.
Is Chegegwa district.
Chegegwa district, yes, please. Congratulations, that's a massive jump. Well done.
Then from private sector, we have a facility from Western region that has demonstrated sustainability of provision of high quality family planning services from private sector in Western region. This is the Gyakahunga Medical Center in Kamwenge district. Yeah, that's it from Western region. We can now have a group photo.
The proprietor of Yakahunga is coming for his award. Congratulations to all of you, all the districts and individual merit awards. We have just one more district, then we complete, one more region, then we complete the merit awards. We're not awarding our consortium partners or some of you our guests. I think we awarded you along the way, but congratulations. Over to the next region, please.
Now we are going to the last region, that is Central region. Central, we have a facility that has really demonstrated excellence in family planning competence based on job mentorship, and this is the Kajansi Health Center for Wakiso District. Then this will be followed by a biostat that has really been very supportive and has demonstrated excellence in improving SRH data quality improvement from the central region. That is Martin Seruyang from Masaka District. Then this will be followed by a district that has really championed sustainability for competence based on job mentorship in provision of FP service provision from central region, and this is none other than Karungu District.
And for Kalungu, we need to give them extra clap. The ADHO will not joke with any partner. You have to show her the data of what you're delivering. So I'm very, very pleased to see that you're holding all of us accountable. And congratulations, Kalungu.
This is going to be followed by the best district trainer in performing and conducting on job-based competence-based mentorship from Central Region. And this is Monica Chovija from Wakiso Epicenter. Then we have a district that has really demonstrated excellence in supporting supply chain management for SRH commodities, and they are able to submit timely orders to NMS, and they have really sustained adequate stock availability, support continuity of FP services in the district. And this is Rakai District. Then we have the district that has demonstrated increase in modern contraceptive prevalence rate from South Central. This is the Wengo District. It has moved from 22% to 33% during project period. Then this will be followed by, where is the Wengo? This will be followed by a district that has also demonstrated increase in modern contraceptive prevalence rate in North Central from 31% to 44%. This is the Ruwero District. And lastly, we have a private facility that in the Central Region that has demonstrated sustainable delivery of high quality FP service provision in the private sector. This is none other than Nyange Medical Center in Wakiso District. Nyange.
Congratulations.
So that's it from my side, and congratulations to the team that supported the delivery of RISE project, and we wish you the best, and we hope we shall continue the working collaboration and support to ensure that we sustain the gains that have been made by RISE project in your respective districts. Thank you, and over to you.
Thank you very much, and thank you, our chief guest, and congratulations, everyone, and for the districts that have won awards for increasing MCPR, and those that have reduced at least 4% points in teenage pregnancy. You will notice we didn't award Yumbe. That was an error. A 2% point is not good enough. At least we're aspiring for 10% reductions as we go ahead. But congratulations, everyone, and thank you so much, our chief guest, for those awards. Okay, we are coming to a close at the end of this, our today's event, which is the RISE National Learning and Transition event. I hope you have learned something. I hope we have inspired partners who are here to deliver more and to deliver equitably across all the regions that we are working with. We will request for a final group photo for all of us, and then we'll have lunch, which is going to be served at the just outside the registration. There is the Victoria concourse. That's where lunch is going to be, and it's already been served. Thank you so much. We look forward to continuing the gains and momentum RISE has delivered through the who, what, and when of the Empower program, and wish all of you a lovely lunch and lovely afternoon. Thank you. If you'd like to be in the group photo, please come up here. Would like to take 5 minutes to be arranged for the group photo. Sorry. Yes, please.
Right, our chief guests could take the first row, and then the rest of us will fit behind this row of seated people. Can we have some more here? So ministry team, the donors, some of our invited partners, please be seated and the rest of us will fit behind you. When the stage is full, then we can cut it off from there.
Please, I'll just remove one chair.
The front row is still empty. Dr. Mugahi. Yeah. Our ministry colleagues, the cultural leaders, the first row is still empty. Okay.
Please, if you're tall
Now,
enough, you
if
go
you
sit
are
at the
tall,
back.
just give space
This place should be for those of us who want to do like this, those who are short.
to the not so endowed as yourself. So all those tall guys, go park yourselves at the back.
Please, colleagues, join the group photo. We're only having one group photo and we can have a few people. Can you see us when we sit here?
I'll really be
Short people lives matter. I'm going to be in the picture. No, chairs won't be able to see us.